Diabetes is a very common presentation in hospital, but for the purposes of today's talk, we will focus specifically on type 2 diabetes. And this is a critical differentiation to make because a type 1 diabetic is typically much more tenuous and you would have to be very vigilant of hyperglycemia and the risk of DKA. For the objectives of today's talk, we're going to develop a pragmatic or practical approach to the inpatient or in-hospital management of glycemic control in a type 2 diabetic patient. The goal of type 2 diabetic management is oral antihyperglycemics plus or minus insulin. However, in hospital, we tend to use insulin therapy preferentially because there can be contraindications to oral agents such as lack of intake or acute kidney injury. Keep in mind that as patients are closer to discharge, we should be working with our teams to transition them back to an oral regimen. For the purpose of today's talk, we're going to focus on insulin therapy and the in-hospital setting. Overall, our in-hospital glycemic targets are slightly higher than our outpatient targets. And in general, a good rule of thumb to remember is a target of 5 to 10. Specifically, this is a target of 5 to 8 preprandially and less than 10 for a random glucose. When prescribing insulin, we want to mimic the physiologic response, and to do so, we usually use the basal bolus insulin therapy technique, otherwise known as BIBIT. With BIBIT, we use a basal therapy to ensure baseline amounts of insulin throughout the day. Bolus therapy mimics the response after each meal. The final component is the correction scale, which adjusts for breakthrough hyperglycemia. To initiate BIBIT therapy, we can either start with the patient's home doses of insulin, or we can calculate a starting dose using 0.5 units per kilogram, taking 50% of that as the total bolus dose over the course of the day, and 50% as the total basal dose. This is simply your starting point, and you'll continue to titrate their insulin based on their blood sugar readings over the course of their admission. Let's look at an example. Our patient has bolus insulin dosed at 5 units in the morning, lunchtime, and evening, as well as an evening basal dose of 15 units. Their blood sugars are read 4 times a day and show readings of 7, 8, 7, and 9 preprandially. These readings are all within our target of 5 to 10, and we're pretty happy with their insulin doses. Now let's say the evening reading was actually 16, which is well outside our target range. What insulin would you have to adjust? Remember that this blood glucose reading is actually reflective of the insulin administered approximately 4 to 6 hours ago. And so if you were to make any changes, a new regimen might include insulin of 5 units in the morning, 7 units at lunchtime, 5 units in the evening, and a basal dose of still 15 units. A key point to make here is you wouldn't actually be adjusting the evening dose of insulin administered. Now let's say our blood sugar readings were actually 3 in the morning, 5, 6, and 6. A reading of 3 in the morning is concerning for nocturnal hypoglycemia. This is the most dangerous form of hypoglycemia because we aren't aware of our symptoms. A morning reading is reflective of the overnight or bedtime dose of insulin, and so the changes we could suggest include decreasing the nighttime basal dose of insulin to perhaps 12 units. Okay, now let's say that the blood sugar readings for your patient are consistently around 16, 15, 15, and 15, so they're all elevated. This suggests that both the basal doses and the bolus doses are insufficient and is a good opportunity to increase the doses of insulin carefully across the board. In an inpatient setting, you can look at how much correction insulin was given to use as a guide to how much insulin you might add across the board. Insulin titration is a bit of an art, and there's no right answer. The best approach is to be safe, go slow, and understand the basic principles. Here are a few extra tips. Remember that hypoglycemia is dangerous, but hyperglycemia can be tolerated. If in doubt, you can always err on lesser insulin and titrate over a few days. If a patient has reduced oral intake, remember that you also have to reduce the insulin. And often in an inpatient setting, some patients actually aren't able to eat at all for either procedures or other complications. In that situation, you should actually suspend all bolus insulin and decrease their basal insulin to about half or 2/3 of their usual dose. In contrast, you can also anticipate when patients may have an increased insulin requirement, and this could be in situations where you're either starting more nutrition or you're starting therapies such as steroids, which often cause hyperglycemia. In that setting, make sure you monitor sugars closely. And finally, remember that insulin is cleared by the kidneys, and so in a setting of acute kidney injury, be a little bit more cautious with insulin and realize that insulin may accumulate over time in the body. Remember that practice makes perfect, but hopefully this helps you get started.